For any health centre to provide good quality, reliable healthcare to patients, we need to invest in water, electricity, medicines, healthcare workers, infrastructure, and so many other things. The Karamoja health system is no different. Karamoja is located in the northeastern part of Uganda, in an area of 35,007 square metres. A little more than 1 million people live here. The area is hot all year long, with a dry season from about October to March and a short dry spell in June, July. It is one of the poorest parts of the country. 74% of the residents here live below the poverty line, compared to the national average of 19.7%. There are so many needs in the Karamoja health system. For one, the health facilities need water. Water is life. The WHO says that every healthcare facility in every setting has safely managed, reliable water, sanitation and hygiene facilities, and practices to meet staff and patient needs in order to provide quality, safe, people-centred care, with particular attention to the needs of women, girls and children. The German Development Corporation, with support from Deutsche Gesellschaft für internationale Zusammenarbeit, GIZ, under GIZ's Enhanced Water Security and Sanitation Programme, ENWASS, implements a project called Strengthening Climate Resilience and Operations and Maintenance of Water Supply Systems of selected health centres in Karamoja. This is funded by the UK Department for International Development, DFID, under its Karamoja Nutrition Programme, KNP. The project is divided into three components. The first component concerns the protection of water resources supplying in selected health centres in Karamoja. The second component analyses the structure of operations and maintenance of the water supply systems in these health centres. And under the third component, the project assesses and improves some selected water supply systems of health centres. Along with these activities, DFID and GIZ found it necessary to learn more about which water solutions create most impact and value, and how do water-related investments in health centres compare to investments in other health centre essentials, for examples in medicine, equipment or drugs. GIZ has therefore engaged our firm, Oxford EPI, to carry out this study. Oxford EPI is a global consultancy firm with extensive experience analysing investments in health and water sectors in East Africa, Uganda and in particular the Karamoja region. We were tasked to provide evidence for what is the best, most reliable source of water for the health facilities. Should we invest money in standalone systems like boreholes, or should we invest it in the grid systems? Health centres in Karamoja also need other resources, like human resources, medicines, equipment, and so many other things that are essential for healthcare centres to deliver a minimum package of quality healthcare to patients. Should we invest in water or all of these other resources? The question is, how do we decide where to put our money? This is a question that many donors are asking these days, as access to funding is becoming more and more challenging. Identifying interventions that yield the highest return on investment is important. The project had two objectives. Firstly, we assessed the value for money of standalone water systems versus water grid supply systems. Secondly, we analysed the value of money of investments into the water supply system overall compared to investments in other factors of functionality of the health centre. To do this, the first thing we did was work together with GIZ and DFID to identify key stakeholders, finalise the methodology, including the health facilities we would assess and the tools that we would use to collect the data. We introduced the project to more than 100 stakeholders at the Interception Workshop in Moroto in December 2019 and discussed the methodology that we thought would give us some answers. Challenges of the water supply system also came up. Together, we selected 11 health facilities to visit and 63 stakeholders to interview in depth as key informants or focus group participants. We collected data from many stakeholders in Karamoja, like health centre staff, local government officials, different institutes from the Ministry of Water and Environment, UNICEF and community members. And in Kampala, at the national level, UNICEF and officials from the Ministry of Health and again the Ministry of Water and Environment. During our visits at the health centres, we assessed their sources of water and asked many questions about cost, supply, maintenance and challenges. We also assessed if the health facility had everything they needed to deliver quality healthcare services using the Services Available and Readiness Assessment. We call it SARA for short. The SARA was created by WHO to help stakeholders understand for each health centre which services are available and how ready the facility is to provide that service. The SARA is a pretty comprehensive survey, asking many questions about what is available on that day at that facility. We then entered all the data collected into DataVenture, a software that allowed us to conduct the analysis and visualization in real time. During the interception phase, we had agreed to use 4E's value for money framework to conduct this analysis. This framework is often used by development partners, including DFID. The 4E's stand for economy, looking at the cost of providing one service versus another. Effectiveness, looking at service units supplied for one system versus another. Efficiency, looking at cost per service unit supplied. And equity, looking at different segments of society and their access to the services. We agreed that the best value investment in water would be defined as the one that is cost effective and cost efficient, meaning that it reliably produces the maximum supply of water. And the same applies to water compared to other health facility essentials. We agreed that the best value here would be judged by the factor which contributes most to the health centre's readiness and functionality. Now let's talk about the results. Out of the 11 health centres we visited, 1 was a hospital, 2 were healthcare centre 4s, 7 were healthcare centre 3s, and 1 was a healthcare centre 2. We found that 5 healthcare centres had standalone water systems, 4 had grid water systems, and 2 had both systems functioning. When calculating cost, we made a few assumptions based on the information we had read as well as discussed with key stakeholders. We found that having both systems was most costly, while being connected to the grid was more economical compared to having a standalone system. One thing that was challenging is one would never install a grid system for one facility alone. So the costs that we have for the grid water system benefit from economies of scale and are lower. When we looked at cost associated with long-term maintenance, again, grid was less expensive for healthcare facilities compared to standalone systems. Which water system was most efficient? We based our assumptions off of use on WHO recommendations for water use in emergency situations. We found that overall, the sites could effectively supply 2/3 of the water needed, and sites with grid-installed water systems were more effective compared to sites with standalone water systems. In terms of efficiency, water produced at health facilities that had both water systems were 8 times less costly per litre compared to water produced by health facilities with only standalone systems. When we looked at equity, we looked at socio-economical differences, and a good proxy for that is urban-rural. Rural areas have less infrastructure and less access to socio-economical opportunities. Therefore, we looked at differences of water cost and supply in urban areas versus rural areas. 7 of the 11 health centres we visited were in rural areas, and we did not see much difference in terms of how many had standalone versus grid system. However, the 2 health centres with both systems were located in urban settings. Our conclusion: health centres that have both grid and standalone water systems appear to be of the most value for money. In these sites, water access was deemed to be available and reliable more often, compared to sites with only standalone or only grid water supply systems. However, grid systems are still not yet available in many parts of Karamoja region. There are many things to consider for a grid system to become a viable option for a community. These include the number of people to be served and other existing infrastructure. Only when the grid system is available in the community can a healthcare facility obtain a connection. The real answer to what is value for money will depend on whether or not connecting to a grid is even possible for that health facility. Next, we analyse the results of Objective 2. If you remember, we wanted to know which investment in a healthcare facility would yield more value for money, Investments in water versus investments in all other aspects of the health centre required for its full functionality. We use the same 4E framework to do this analysis. This means we looked at economy, effectiveness, efficiency and equity for the investment in other health facility essentials and compared their results to those of the water investment. Specifically, we looked at the cost of electricity, universal precautions, human resources, medicines and laboratories, diagnostic capacity, as well as other amenities that WHO has stated are important for healthcare facilities to deliver care. We then combined them so that we could compare them to water in terms of cost, economy, effectiveness, efficiency and equity. The results also show that there was not a single healthcare facility where these essentials are available all the time. For example, facilities reported that basic equipment and supplies are only available 36% of the time, while electricity was available and reliable 45.5% of the time. In these same facilities, water was available and reliable 68% of the time. On the day of the visit to all the HCs, we did not find a single facility with all essentials, including water, available all the time. The results show that investment in water costs less than investment in all other essentials combined. Cost per patient for all other health essentials were 2 to 10 times higher compared to the cost for water, depending on the facility and if the visit was outpatient or inpatient. On the surface, it would therefore appear that the investment in water are more cost-effective compared to investment in other aspects of care. However, this is misleading, since other essentials are required in order to deliver health services in a health facility. Water alone is not a cure for those already sick. The finding also suggests that supplying health services in facilities with standalone water system is more costly compared to those with grid systems. However, this is likely due to a number of other factors, including geography and access. When we looked at equity, we found fairly stark disparities. In general, less money is spent on all healthcare essentials in rural areas, except water. This is likely due to a number of other factors, including geography, the number of people served, and the type of service they provide. Our conclusion: other health commodities cost more than water systems. Water systems also appear more effective, efficient and equitable compared to other health essentials at the facility. On the surface, water systems are more value for money. However, health facilities cannot provide support without the other essential items. To increase effectiveness, consider improving existing water systems to where they supply more waters to users and are more reliable for users. For example, fix pumps, broken parts, etc., and strengthen the management structure for better management in the future. To improve water efficiency, consider moving to grid water sources as much as possible. Given that the installation cost is lower and maintenance costs over time are lower, dual systems provide more security against water shortages. However, there are a number of factors to consider: budget, Ugandan government plans, distance from town, infrastructure development, availability of grid water systems, etc. To improve equity, consider strengthening the overall support for the health facilities, especially in rural areas. It is likely that improved water sources, along with improved health system performance, will increase the number of patients seen at the facility. This may positively affect the effectiveness of the health facility in delivering quality health services for its catchment population. That's the end of our study, ladies and gentlemen. Please leave your comments and feedback here. They are important. You can also receive a copy of the full report by emailing us at info@oxfordepi.com or andrea.scala@giz.de.